This poster is about a rare case of lupus cerebritis presenting as refractory rhombencephalitis. The prevalence of CNS manifestation in patients with systemic lupus erythematosus or SLE is controversial. One study found that 4.3% of SLE patients had major CNS manifestations. The manifestations of SLE cerebritis can range from memory changes to seizure and stroke. However, the brainstem is rarely involved. Here we present a rare case of refractory SLE rhombencephalitis. Case is describing a 22-year-old Haitian female with a previous history of SLE on prednisone, hydroxychloroquine, and methotrexate. She presented to the emergency department with acute headache, diplopia, unsteady gait, phonophobia, and photophobia. Her neurological exam revealed bilateral abducens, nerve palsy, and hyperreflexia. Brain MRI, as is shown in the first picture, revealed diffuse increased T2 signals within the pons, dorsal medulla, and cerebral peduncles, and punctate area of restricted diffusions in the DWI. MRI of the brain, as shown in the second picture, did not demonstrate any stenosis of cerebral or vertebrobasilar arteries. Lumbar puncture was significant for pleocytosis, but cultures and viral serologies were negative. These findings were consistent with rhombencephalitis. Further workup demonstrated that the patient had an elevated ANA, anti-double-strand DNA, anti-RNP, and anti-chromatin and anti-Smith, and a low level of C3 and C4. The patient was then diagnosed with SLE rhombencephalitis. Initially, IV methylprednisone and IVIG were started. Unfortunately, her encephalopathy got worse. Her neurology exam worsened and her GCS was 3 out of 15 of sedation. She then developed hypotension requiring vasopressors. Next, IV cyclophosphamide and oral mycophenolate were initiated. The patient developed cutaneous manifestations of SLE and anosarco at that time. During the course of her hospitalization, she developed recurrent pericardial effusions requiring pericardiocentesis. Her hemoglobin trended down to 4 grams per deciliter, but transfusions was declined due to religious reasons. Repeat MRI of the brain showed expansion and worsening of pontine involvement. Her family then agreed to tracheostomy and PEG tube placement. 3 weeks after receiving cyclophosphamide, her neurological exam began to improve. Complement levels normalized and anti-double-strand DNA decreased to 0. 3 months after her hospital admission, the patient's cognitive function returned to baseline and motor function significantly improved. As a conclusion, given its location, SLE rhombencephalitis confers a high risk of mortality. Prompt diagnosis and treatment improved mortality and complication. LP, MRI of the brain, and antibodies are crucial to diagnose SLE rhombencephalitis from more common SLE CNS manifestations such as seizure, stroke, and aseptic meningitis. Although the pathophysiology of SLE cerebritis is not completely understood, many mechanisms have been postulated, including antineuronal antibodies, cytokines, and immune complexes. The role of cyclophosphamide in CNS lupus is useful in patients with acute onset neurologic symptoms, increased protein in CSF, and in patients with cerebral edema. Thank you for your attention.